we're going to talk about the update in regard to the new WHO classification for thyroid tumors. So I guess the best way to start this talk is by this statement from the French-Canadian pathologist, which was done a long time ago, maybe 70 years ago, when he said that no classification is more difficult to establish than that of thyroid carcinoma. Of all cancers, they teach perhaps the greatest lesson of humility to histopathologists. So what is the basis of this new WHO 2022 classification of thyroid neoplasm? Obviously, the basis is the same as has been done for many, many years, for decades: cell of origin, histopathology, how the tumor is growing, of course, now molecular profile. And perhaps what really made the difference here is we really took into account the biologic behavior of the tumor in many of the entities. So this is the old classification that I put here for your reference. And this is the new one. And you can see there are plenty of changes. You notice one interesting thing here. So we brought the concept of low-risk neoplasm. So again, a behavioral concept. So I have to tell you that some of the changes are clinically important. For example, the one that relate to the definition of non-invasive follicular thyroid neoplasm with papillary-like nuclear features, or NIFT-P. The one related to the position of invasive encapsulated follicular vent of papillary carcinoma, which is discussed separately from papillary thyroid carcinoma, from classical papillary carcinoma. The introduction of the new concept of high-grade follicular cell-derived thyroid carcinoma. The fact that now squamous cell carcinoma is a form of anaplastic carcinoma and not discussed separately. Another important change is that cribriform modular thyroid carcinoma, which was before just a subtype of papillary carcinoma, is now a separate entity, is not considered a papillary carcinoma, it's considered a tumor of uncertain histogenesis. And finally, in regard to medullary thyroid carcinoma, we introduced the concept of grading. Now, there are also other changes, which in my opinion are of relatively little clinical impact. For example, the term variant is replaced by the term subtype. Because HER2 cell is a misnomer, we prefer to use term for HER2 cell adenoma and HER2 cell carcinoma as we prefer to use the term oncocytic adenoma, oncocytic carcinoma. The entity known, a very rare entity known as sclerosing mucoepidermoid thyroid carcinoma is considered a tumor of uncertain histogenesis. We try to kill the term papillary carcinoma because really it's not a histologic subtype of papillary carcinoma, it's based on size. And instead of just saying papillary microcarcinoma, we're gonna have to say papillary carcinoma classic, or 0.5 centimeters, so on. Another also a change of little clinical impact is that the entity follicular adenoma with papillary features is considered now separate from follicular adenoma. And finally, you know, in view of the controversy in regard to whether multinodular goiter is a collection of hyperplastic nodules or a benign neoplastic lesion or a mixture of both, in order to not address this controversy, in order to calm everybody, so to speak, we introduced the term of follicular nodule disease for this multifocal hyperplastic neoplastic lesion that occur in the clinical setting of multinodular goiter. So now let's start with the changes that have significant impact on the patient. Let's start with our nemesis, our big enemy, the follicular vat of papillocarcinoma and its associated lesion known as NIFT-P. So here I'm going to take a kind of unusual type of approach. I'm going to take you through the history of the classification of thyroid carcinoma to let you know how we got there and how we are trying to fix it. So the story starts in the 1950s. At that time, it was very easy to be a thyroid pathologist because, you labeled the lesion just based on the growth pattern. If the tumor had papillae, you call it papillary carcinoma. If the carcinoma had follicles, follicular carcinoma. If it's a mixture of papilla and follicles, then it's called mixed papillary and follicular carcinoma. But a big change happened in the 1960s and 70s. A pathologist from California, Dr. Stuart Lindsay, in 1960, described the papillary carcinoma nuclei, and he realized that this nuclear characteristic like clearing, overlapping, irregular nuclear membrane are found not only in papillary tumors, but also in tumor with a follicular growth pattern. And he coined the term follicular variant of papillary carcinoma in a monograph that he published that is actually online if some of you are interested in looking at it. But really, this did not take off. It's Dr. Juan Rosay that we all know that in 1977 put this entity on the map where he described the follicular vat of papillary carcinoma in a more detailed fashion. So what Dr. Rosay did in this article, which contains 6 cases, he reported on tumor growing into follicles with papillary carcinoma nuclei. And almost all of these tumors had lymph node metastasis. So there is a little detail that nobody gave attention to, is that all of Dr. Rosay's cases lacked complete encapsulation. So these tumors were not completely encapsulated. They actually were partially or not encapsulated and infiltrative. But after that article that got a lot of success, so to speak, pathologists, I don't know why, I don't know who started in the 1980s to call any tumor that was completely encapsulated with follicular growth, with the nuclear feature of papillary carcinoma. They started to call any of these tumors as encapsulated non-invasive follicular variant as carcinoma, even if it didn't contain any invasion. So encapsulated papillary carcinoma, non-invasive follicular variant. And unfortunately, no meticulous study of the outcome of that particular encapsulated follicular variant non-invasive was done for 26 years. So that led to a widespread use of the follicular variant term and an important decline of follicular adenoma and carcinoma diagnosis. We have to wait until the year 2000 to see some change. What happened at that time, we started to understand better the molecular profile of papillary carcinoma, specifically the follicular variant of papillary carcinoma. This entity at the molecular profile is different from classical papillary carcinoma, and you can see that it is much closer to follicular adenoma and carcinoma. And one of the first paper on this subject done by Yuri Nikiforov, who is now at the University of Pittsburgh, where we genotype a bunch of follicular variant of papillary carcinoma. And you can see that they have a lot of RAS mutation, like follicular adenoma and carcinoma, and it's different from classical papillary carcinoma. They have very little BRAF mutation, different from follicular adenoma, like follicular adenoma and carcinoma, and different from classical papillary carcinoma. And they also have very little red PTC mutation, similar to follicular adenoma, and quite different from classical papillary carcinoma. At that time, at Memorial, we were also interested into this classification of follicular variant. At that time, we ran a paper using comparative genomic hybridization and the old style, actually. And you can see here on this ideogram the losses of chromosome in red and the gains in green. And you don't need to be a cytogenesis to notice that the follicular variant of papillary carcinoma is very different from classical papillary carcinoma as far as its chromosomal gains and losses. So after looking at this data, one should ask themselves, does the follicular variant of papillary carcinoma behave like papillary carcinoma? Is it really a subtype of papillary carcinoma or not? And that's why when I undertook this study with my colleagues at Memorial and my colleague Giovanni Tallini from the University of Bologna, this was some time ago in 2006, so we're talking about 16 years ago. And what we did here, we looked at, in our hospital, at a large number of follicular lesions that were called follicular variant, follicular adenoma, and follicular carcinoma between 1980 and 1995. We excluded a lot tumors with a lot of sub-centimeter separate foci of separate foci of papillary carcinoma, because how can you study the uninodular follicular variant if it's living with 10, 15 micro carcinoma? We also excluded the sub-centimeter lesions because we know they do very well. So what we got is two types of animals, so to speak. The encapsulated follicular variant, when you see the capsule here, and there's clearly a follicular growth pattern, and the inset you see tumor with enlarged clear overlapping nuclei, so the typical nuclear features of papillary carcinoma. On the other hand, you have a totally different animal here, which is a tumor with a lot of fibrosis, and these tumors lack a complete capsule as they infiltrate the you can see the neoplastic follicles infiltrating in between the non-neoplastic ones. And when you look at the lymph node spread of this lesion, it's really shocking to see that the infiltrative follicular variant have 65% lymph node metastasis, basically like classical papillary carcinoma. And this is what Dr. Ghossein described in 1977. And the other one, the encapsulated follicular variant, have very little lymph node metastasis. Those with capsular and or vascular invasion have 17% only. And those who are non-invasive instead, in that study, have 0% lymph node metastasis. But perhaps the most important finding from this study is there were encapsulated follicular variant without invasion treated by lobectomy alone. And there were 31 cases, and there was no recurrence and no lymph node metastasis, despite a median follow-up of 11 years and a median size of 2.3 centimeters. Now, other studies have confirmed these findings. There was one case from the Brigham and Women's Hospital in Boston where the patient recurred, but the tumor was at the margin, so we don't know the capsule invasion status. Dr. Virginia Livolsi, that we all know, published one case that actually had distant met, but after I spoke with Dr. Livolsi, she told me that the whole capsule was not actually examined in this case, so we don't know really if there was or not capsular or vascular invasion. Now, I don't want you to leave this talk thinking that any encapsulated follicular vent will not give you problems. What I was talking about were the encapsulated follicular vent without invasion. But if you have invasion, especially if you have the angio invasion, you can actually have problem, like in this particular case where you have vascular invasion here and here, and the nuclear feature of papillary carcinoma here, and you can see that this nasty tumor traveled to the rib, interestingly bypassing the lymph node, which is a typical behavior of follicular carcinoma or a RAS mutated tumor. So since we have two subtypes of follicular variant, the encapsulated and infiltrative, in 2010, we were interested to see what is the genotype. And if you look at the data here, you can see that the encapsulated follicular variant have no BRAF mutation. This is a study we did in 2010. And while they have 36% RAS mutation, in contrast, the infiltrative follicular variant have BRAF mutations, 26% their study, some RAS mutation, but not as much as the encapsulated follicular variant. And the encapsulated follicular variant has a no-RET PTC mutation and can have PAX8 PPR gamma. So in 2014, a very important study was performed in the United States it was a big network of multiple hospitals funded by the US government, the federal government, where genotyping of 400, almost 500 papillary carcinoma was done, but really deep genotyping using 9 molecular platforms. And this study has shown that follicular variant as a whole is clearly a distinct molecular entity. You can see here that in almost every platform used, whether it's messenger RNA, microRNA, methylation platform, or protein expression, the follicular variant of papillary carcinoma has a distinct profile different from classical and dorsal. So you can see here, and we even put that in our paper in 2006, that the follicular variant of papillary carcinoma seems to be composed of 2 entities. To speak, the encapsulated follicular variant, which is closer to follicular adenoma and follicular carcinoma, depending whether it has invasion or not, it will behave like follicular adenoma. If it has invasion, it will behave like follicular carcinoma. And the infiltrative follicular variant that is much closer to classical papillary carcinoma. And actually, in 2006, when we did this paper with Giovanni, we thought that maybe this entity should be reclassified as a close entity to the follicular adenoma carcinoma group of tumor. So countless number of patients with non-invasive follicular variant will be treated by lobectomy only and spare the unnecessary side effect of therapy with its attached morbidity, financial cost, and also the psychosocial impact of a cancer diagnosis. But there were obstacles. We failed to do that. Obstacles from endocrinologists who really wanted to give radioactive iodine right and left, who didn't care about the size of the lesion because of the thinking that radioactive iodine does not have side effects. Actually, it has side effects. It's can fry your salivary gland, so you can have tooth problems, even with small. It can dry the lacrimal glands. It lowers the blood count, the sperm count. Even it has, in certain doses, a small, but definitely risk of leukemia. Also, we had to battle surgeons who, many, even on the same island in Manhattan, in New York, where I live, did not really understand the biologic behavior of papillary carcinoma. They wanted to overtreat microcarcinoma. And finally, the people to blame are us, expert pathologists, who failed to communicate the extremely indolent nature of the non-invasive encapsulated follicular variant. because you send it to one pathologist, they call it benign, another malignant, and when they call it malignant, they don't tell you that this is a very, very indolent lesion. So after 30 long years of over-calling and over-treating, finally things came to an end with this study were done by a large number of pathologists that I'm sure you were aware about, most of you, if you work in thyroid, in JAMA Oncology in April 2016, related to the nomenclature revision for encapsulated follicular variant of papillary thyroid carcinoma. So what we did in this study, we were 24 endocrine pathologists from throughout the world. We had a surgeon, two endocrinologists, and even one psychiatrist whose main really interest was the impact of the nomenclature of disease on patients. And he told us that, you know, the only fact that you label a patient as a cancer patient, that will create enough anxiety so the patient will accept to be overtreated. So in that study, there were 109 non-invasive encapsulated cases that were analyzed, not treated with radioactive iodine. And each case had at least 10 years follow-up, so a median follow-up of 13 years, and there was no recurrence. And these cases were approved. We concurred that this follicular variant, it was by 24 endocrine pathologists agreed on that, and only one was aware of the outcome of these cases. So we choose this term that's kind of long, but it hopefully it is clear. It's a non-invasive we decided to call the encapsulated follicular variant non-invasive as non-invasive follicular thyroid neoplasm with papillary-like nuclear features. Obviously, adequate sampling of the entire tumor capsule, actually sampling of the entire capsule should be done to arrive to this diagnosis. So how do we diagnose NIFT-P? So the most important thing is to exclude vascular and capsular invasion. You also have to be sure the tumor is obviously encapsulated or clearly demarcated. Obviously, it has the nuclear features of papillary carcinoma. You have to exclude any high-grade features like tumor necrosis or mitotic activity of 3 mitosis are not. And then there is a specific point of contention here, which is the number of papillae. What happens in papillary carcinomas, I'll show you, the more papillae you have in a lesion, the higher chance you have of lymph node metastasis. But we showed that we can accept less than 1% papillae. However, after this study was performed, and published, 3 studies showed nodal metastasis in NIFT-P with 0% papillae and, like for example, 2 to 5% nodal metastasis in 0% papillae, and 3% is less than 1% papillae. Now, however, 2 of the papers did not exclude cases with separate papillary carcinoma. So then you cannot really judge here. You cannot tell whether the lymph node mets comes from the NIFT-P in question or from the separate papillary carcinoma living with it. Then there's only one really paper with, I think, had a good study design because they excluded separate papillary carcinoma. However, they did not analyze the primary and the met at the molecular level. And we know that sometimes you can have a metastasis from a papillary microcarcinoma that is not picked up by the sampling or that is embedded within the block or that has regressed. So because of this paper, there was a reaction by some of us in the NIFT-P group, and we tried to change the criteria from less than 1% true papillae to no papillae allowed. I thought personally that was too much. It was a too nervous reaction. So I undertook this study with a long title, where basically, with, again, my colleague Giovanni Tallini, where we assess the percentage of papillae in encapsulated papillary carcinoma, 235 unifocal encapsulated papillary carcinoma. I won't show you all the details, but I will show you first that there was a clearly relationship between the percentage of papillae, this column here going up, and the chances of lymph node metastasis. For example, nobody, whether even if in the cases that had invasion, if you have less than 1% papillae, you don't have lymph node metastasis. But of course, if you have 50% or more papillae, you start to have much more lymph node metastasis. Same correlation between the amount of papillae and the presence of BRAF. If the number of papillae go up, the chances of the tumor being BRAF positive increase. And if the number of papillae goes down, the chance of the tumor being RAS mutated also increases. But perhaps more important for this discussion today here is what happened to those encapsulated non-invasive papillary carcinoma. So here you have to wait for 10% papillae to start to have lymph node metastasis. Again, here the same relationship. The more papillae you have, the more BRAF mutations you have, and the less papillae you have, the more RAS mutation you have. So I repeat here, you need 10% of papillae to have lymph node metastasis, encapsulated non-invasive papillary carcinoma. So because of this study and many others, we arrived to the conclusion in the WHO that criteria should remain. It's okay to have a few papillae in the lesion. However, we added one criterion that if you have BRAF V600E positive, then the lesion is not a NIFP anymore. I have seen cases that look NIFP under the microscope, but after you do BRAF V600, they are positive, are usually cases that contain some tall cells. However, I've seen only one NIFP. I'm sure it is a NIFP histologically that was BRAF positive, but because, you know, biology is not perfect. So these are now the new criteria for NIFP. The less than 1% papillary remains, but BRAF V600E should be negative, should not be positive. But we also expanded the NIFP concept. Initially, some pathologists were afraid that sub-centimeter NIFP cannot be diagnosed as NIFP. Now, our paper, another group, also showed that this is possible. Now, also some pathologists, especially in England, in the UK, were nervous regarding NIFP with oncocytic features. We showed in a paper that these also do not recur, and they can be diagnosed. And finally, some endocrinologists were very nervous about the very large NIFP, more than 4 centimeters. We also showed that these do not recur. Obviously, in that situation, I would advise everybody to be super careful and to really submit the entire capsule. That's no way. Anyway, in any NIFP, you have to submit the entire capsule. So let's look at the impact of NIFP. Why are we doing all this? In the latest paper show an impact of probably 47,000 cases worldwide each year, thinking that if you include NIFP in the papillary carcinoma group, they represent 9% of papillary carcinoma with significant variation. You have much more of this diagnosis in North America and much less in Asia. Now, obviously, but every time you spare a patient carcinoma diagnosis, you, especially if the tumor is large, you're gonna diminish the side effect of completion thyroidectomy, like recurrent nerve injury, hypoparathyroidism, or thyroid hormone replacement. You can diminish the side effect of radioactive iodine therapy. We spoke about it. of course, the healthcare costs, these are very odd numbers, but it's much more expensive in the US to have a completion lobectomy to give radioactive iodine. And also the psychological and financial burden of a cancer diagnosis. We never talk about it, but there are definitely big psychological and financial burden. For example, in some countries, the bank won't give you a loan to buy an apartment if you have a cancer diagnosis. So in addition to the changes related to NIFT-P, based on all the study I showed you, it's clear that encapsulated follicular vent with invasion is different from papillary carcinoma because it has a different biologic behavior, rare nodal spread, if any, a different molecular profile, RAS. Really, it behaves like a follicular carcinoma. We didn't change the name to follicular carcinoma, but at least we started to separate it by put it in as a separate entity from papillary carcinoma. It's not under the papillary carcinoma section or chapter. So finally, we're gonna close this issue of follicular vent FDP with this statement from Charles Darwin, who said that to kill an error is as a good service and sometimes even better than establishing a new truth or fact. Now let's jump to another subject, which is the subject of thyroid carcinoma with intermediate prognosis. So all clinicians, this is a statement from Dr. Warner, who was a pathologist at the Mayo Clinic, and he said that all clinicians used to think that the classification of thyroid cancer was very simple. There was a group of well-differentiated, slow-growing tumor that never killed anybody, and a group of rapidly growing tumor that killed everybody. And Dr. Rosar used to tell us as his fellow that when he was interested in thyroid at Washington University in St. Louis, Missouri, one of his of the surgeon there made fun of him, said, "There's nothing about thyroid, it's very boring, that you have either tumor that don't kill anybody or tumor that kill everybody." Well, that surgeon was wrong. Dr. Rosar was right. There are tumors in between. They have been labeled for many years as poorly differentiated thyroid carcinoma. They are tumor of follicular cell origin, showing histologic and prognostic features intermediate between well-differentiated thyroid carcinoma like papillary carcinoma and anaplastic carcinoma. And here we have to thank Dr. Ozai for putting this entity on the map in 1984, where he described insular carcinoma. These are tumors with an insular, insulae in Latin means islands, islands of tumor cells, and they resemble very much tumor, and Dr. Ozai acknowledged it in his paper that was described by the German pathologist Paul Langhans in, Theodor Langhans in 1907 as proliferating stroma. So when you have a solid trabecular insular growth pattern, when you have necrosis, capsular and vascular invasion, everybody agrees, and you don't have anaplastic feature, everybody agrees that these tumors are poorly differentiated thyroid carcinoma. But what do you do if you have solid growth pattern alone or mitosis necrosis alone? Here is the rub, here where people really disagree. So let's see two approaches to the issue. The first one was done in 2004 by this very good group from Italy, Dr. Mauro Papotti, where they defined poorly differentiated thyroid carcinoma on the basis of trabecular solid insular growth pattern, irrespective of mitosis and necrosis. And if you look at their data, the cases are really in between well-differentiated thyroid carcinoma and anaplastic thyroid carcinoma, 83% of survival at 5 years. But when they developed a numerical scoring system, and the main component of that scoring system is necrosis, you can see that the cases with necrosis do very well. They even do better than papillary carcinoma. So clearly, I don't think it's a good idea to call something poorly differentiated thyroid carcinoma when, as a group, it behaves better than papillary carcinoma. I don't know if there's any tumor carcinoma in the human body that behaves better than papillary carcinoma. But when you have necrosis, the tumor is in between well-differentiated and anaplastic thyroid carcinoma. So, however, there was an opposite view, and I had this idea in 2006, say, why don't we define them on the basis of mitosis and necrosis, irrespective of growth patterns? So basically, the opposite concept. And when you look at these cases defined solely on the basis of mitosis, I took 5 mitosis per 10 hyperview and or tumor necrosis, you can see that you have cases like the one on the left, where they have a solid or nested growth pattern, and they contain necrosis. These are cases that everybody agrees upon are poorly differentiated thyroid carcinoma. And you have cases with papillae or follicular growth pattern, but with necrosis. And here we at Memorial for many years were the only people labeling this tumor fully differentiated thyroid carcinoma. So when you look at poorly differentiated carcinoma defined on the basis of mitosis and necrosis, they have a 5-year survival at 60%. So really in between well-differentiated and anaplastic. And when you look at the variables that affect outcome with this group of tumor, things like margin and extrathyroid extension, of course, make a lot of sense and will guide the outcome. But probably what is more interesting, what did not influence survival? The growth pattern, solid versus follicular papillary, did not influence growth pattern, as well as the cell type. So after this, our paper, a group of pathologists gathered in Torino, Italy, led by Dr. Zai, where they came with this definition for poorly differentiated carcinoma that has been adopted in the latest WHO, has been worldwide used, where you need to have solid nested insular growth pattern. You need to have an absence of the nuclear features of papillary carcinoma, at least one of the following features: a mitotic index of 3 mitoses and 10. So here there is congruence with the Memorial approach. You have at least to have tumor necrosis or something called convoluted nuclei, which I understood mean hyperchromatic papillary carcinoma nuclei. So when you look at the data here, also the tumor are in between papillary and anaplastic, poorly differentiated. However, when you look at all the data, all the non-anaplastic cases, those cases without necrosis, whether they are papillary or poorly differentiated, they do very, very well. They behave like papillary carcinoma. So here again, you can see that it doesn't make much sense to call a tumor poorly differentiated when it has a behavior similar to papillary carcinoma. So we at Memorial for many years have used the poorly differentiated thyroid carcinoma definition based on mitosis and necrosis, because it's the main cause of radioactive iodine refractory disease, and most patients who die of non-anaplastic carcinoma die of radioactive iodine refractory disease. Many of these radioactive iodine refractory poorly differentiated thyroid carcinoma are initially diagnosed as a classical papillary carcinoma, HER2 cell or follicular carcinoma. And here you have to put yourself in the shoes of the clinician when she or he has to face a patient with classical papillary. They usually tell them, you have one of the most indolent tumor in the human body. Congratulations. We will, hopefully when I retire, I will transfer you to my partner who will succeed me. Imagine the deception of this clinician and patient when the patient comes back not only with a recurrence after 3 or 4 years, but also with a tumor that is refractory to radioactive iodine, and the patient has to be sent to a tertiary care center like Memorial or MD Anderson or Tata Memorial for targeted therapy. We also did a study on non-anaplastic thyroid carcinoma and found out that the main cause of death from non-anaplastic thyroid carcinoma are these poorly differentiated thyroid carcinoma defined on the basis of mitosis and necrosis. To bring this to life, so to speak, look at this case of a 72-year-old man with a 5.5 centimeter mass. The mass has a solid nested growth pattern. It has a high mitotic rate, but clear nuclei. So this case, if you use the Turin proposal, will be called papillary carcinoma solid variant, which has a 90% survival at 10 years. If you use the Memorial definition, it would be a poorly differentiated carcinoma. And what happened to this patient? Unfortunately, the patient died 4 years after diagnosis of vertebral and lung metastasis. So this is here the price of, in my opinion, not having the ideal nomenclature. So what we did in the WHO, we reconciled these two definitions. So now for intermediate prognosis follicular cell-derived carcinoma, we have one appellation, one name, follicular-derived carcinoma high grade. The tumor has to be invasive, and it has to have high-grade feature, either by the presence of mitotic count and tumor necrosis, and very important, no anaplastic histology. So this new entity here has two subtypes. Poorly differentiated thyroid carcinoma defined on the basis of the Turin proposal, and differentiated high-grade thyroid carcinoma that are defined, as we show you, using the Memorial definition. So here is going into details. So I repeat for the Turin proposal. So if you have a tumor with a solid growth pattern and no features of papillary carcinoma, you need to have one of the following three features: a mitotic count, tumor necrosis, or convoluted nuclei. Now, that was the 2017 definition of poorly differentiated thyroid carcinoma. And this tumor will be called poorly differentiated because if you you define differentiation as how close the tumor is from the adult organ, this tumor looks poorly differentiated because they have a solid instead of follicular growth that are closer to the fetal thyroid organ. However, you have high-grade tumor with a lot of mitosis and necrosis that their architecture is close to the adult organ. They have papillae or follicles. So these tumors that were not included in the old poorly differentiated definition, but now are included under follicular-derived carcinoma high-grade, are called differentiated high-grade thyroid carcinoma. Here you can have papillary and follicular growth, like the tumor above here, with necrosis that is needed, either tumor necrosis or a mitotic count of 5 per 2 square millimeter, one of those, and no anaplastic features. And these two tumors have the same outcome. They have, however, overall different molecular profile. The poorly differentiated thyroid carcinoma, because it excludes tumor with papillary carcinoma nuclei, is mainly a RAS mutated driven tumor with very few BRAF cases, and the differentiated high-grade thyroid carcinoma are tumor that are mainly BRAF driven because they include cases with papillary carcinoma nuclei. So that what I showed you was a very important change in the WHO. Another change is the entity squamous cell carcinoma of the thyroid. So in the 2017 WHO, this was considered a separate entity from anaplastic carcinoma. Now it's a form of anaplastic carcinoma. And the reason for that, first of all, let me tell you how it is defined in the 2017 WHO. It was defined as a tumor composed entirely of tumor cell with squamous differentiation. No papillary carcinoma with it, no follicular carcinoma with it. And we looked at this tumor in the paper that we published. We found out that 60% have BRAF mutations. And also we found out that the outcome, as you see from the Kaplan-Meier curves on the left, are similar to anaplastic carcinoma as a whole, clearly showing that this tumor deserves to be just a subtype of anaplastic carcinoma. Now, there is an important detail regarding anaplastic carcinoma that is not a classification issue really, but I really want to communicate to you because that has been a game changer in the treatment. Every time you have an anaplastic carcinoma, it's mandatory to check the BRAF status. It can be done using immunohistochemistry, which is quite rapid, or genotyping. And this is crucial because those patients who are BRAF mutated, as was shown by this study, when you give them BRAF inhibitor and MEK inhibitor, this BRAF V600E mutated anaplastic carcinoma, there is a chance that they will become resectable. And we have seen high pathologic response rate, and there is durable local regional control. And now actually it's an FDA approved and a standard treatment for BRAF V600E mutated anaplastic carcinoma. So it's really, once you have an anaplastic carcinoma, it's really an emergency in my hospital. We have to tell them before the weekend whether it is BRAF mutated or not. And this is just to show you this incredible PET scan of treatment and post-treatment, and after that the tumor can be resected. It won't save the life of the patient, but they will be able for many years, for a few months, at least many months, or even years, to not have local regional problems. Another change is of clinical significance in the WHO is the one related to the entity cribriform molar variant of papillary carcinoma. So these tumors we know now do not have BRAF mutations. Rarely they have RAS or PIK3CA mutation. The main genetic problem of this tumor is a disturbance in the beta-catenin pathway. That's why when they occur within the setting of familial adenomatous polyposis, they have the APC gene is not functioning, and the beta-catenin is accumulated in this tumor. Any problem in the beta-catenin pathway will lead to beta-catenin accumulation and is typical of this entity. Other important finding that they have always TTF1 expression, but they have an absence of focal weak PAX8 and thyroglobulin expression. So based on that, many clinicians and pathologists think that because this tumor do not make any thyroglobulin, because this tumor don't have PAX8, radioactive iodine may not be needed in this tumor. But this is something that is new, that has to be really demonstrated. But I can tell you, we had a 16-year-old with the cribriform molar thyroid carcinoma with metastasis, and the clinician elected not to give radioactive iodine because, in their opinion, this tumor is not follicular cell derived. So that's why this tumor is put under the category of uncertain histogenesis. Now, let me tell you about a very important change with the issue regarding medullary thyroid carcinoma grading. Since the definite histologic description of medullary thyroid carcinoma in 1959 by this physician from the Cleveland Clinic, including Dr. John Beachhazen and Hock, who described the torsal variant, we have been using clinical and molecular characteristic to stratify these patients. Like, for example, age, of course, stage, sex, serum, CA, and calcitonin. But bizarrely, no grading system has been used. And this is surprising because we know that medullary thyroid carcinoma is a neuroendocrine tumor, and we know that neuroendocrine tumors are prone to grading since there are very well established pulmonary and pancreatic neuroendocrine neoplasms that have well validated and accepted histologic grading schemes. This state of affair remained until 2020, where two groups, our group from Memorial and the group of Anthony Gill in Sydney, Australia, published two grading system of medullary thyroid carcinoma. Our grading system, published a little bit earlier than theirs, was based on tumor necrosis and high mitotic rate and was an independent predictor of poor outcome. A few months later, they published their own system. The main difference between these two systems, that is, one is a two-tiered approach, ours, very simple. You put a tumor in the high-grade category if you have the mitotic index of 5 per 2 square millimeter and or tumor necrosis. The CISIS system is more sophisticated. It had a three-tiered approach with an intermediate grade that is a combination of low mitotic count and tumor necrosis, as well as high mitotic count without tumor necrosis. We learned a lot from these two papers. You can see here the Memorial data, the 144 patient on univariate analysis. We learned that histopathologic parameters such as fibrosis were not prognostically significant. Now, in addition to mitosis and necrosis, pleomorphic nuclei made a difference, encapsulation, vascular invasion, extrathyroid extension margin, and node size. This is by univariate analysis. But when you go by multivariate analysis, all falls off, and the only really histopathologic feature that matters are mitosis and necrosis. The Sydney data had somewhat similar results. After univariate and multivariate analysis, again, the only histologic parameters that matters are mitosis and necrosis. Fibrosis, amyloid nuclear grade spindle cell, whether you have them or not, prominent nuclear and vascular invasion, all these do not make a difference. Now, after these two papers, a paper from Brigham and Women's Hospital by Dr. Justine Barletta at Boston validated both of these grading systems in a genotype cohort of sporadic medullary carcinoma. That is great. These papers are great, but they're not enough. We need a universal grading system, and we need one and in order to have one, we need consensus cutoff for all indices. We need a large cohort from multiple international centers. So this is where we published the International Medullary Thyroid Carcinoma Grading System in the Journal of Clinical Oncology. This was a very nice collaborative effort. We gathered 327 patients with resected medullary thyroid carcinoma, cases from Sydney, Australia, from Institut Gustave Roussy in Villejuif, France, led by Dr. Abir Guzlan, the Memorial cases from the University of Bologna by Dr. Giovanni Tallini, and cases from Brigham and Women's Hospital by Dr. Justine Barletta. We, of course, counted mitosis at hotspots per 2 square millimeters, which is equivalent to 10 high power field on most microscope. We did the Ki-67 count the same way it's done in neuroendocrine tumor with at least 500 cells. We looked for tumor necrosis and a large number of clinical pathologic parameters such as sex, age, tumor size, and of course, stage and status of reaction line mutation. And as far as prognostic endpoints, we looked for overall disease-specific, local-regional free, and distant metastasis-free survival. Now, all the cases were looked at by people who are used to head and neck to read thyroid tumor, whether they are endocrine or head and neck pathologists. One point here I want to make that we didn't assess the extent of tumor necrosis. We just coded them as present or absent. And this is an example of tumor necrosis. This should be differentiated from FNA-induced tumor necrosis. There is no fibrovascular proliferation. You have nuclear debris, abrupt necrosis, so to speak. And you notice here, interestingly, that there's not much nuclear pleomorphism in this area of necrosis. So what we did on this large cohort, we assayed the Memorial system, the Sydney grading system, and 8 other potential grading schemes using variance cutoffs for mitotic index, Ki-67, and the tumor necrosis. Finally, all the results were gathered. We held a consensus conference, and a single system was agreed upon, named the International Medullary Thyroid Carcinoma Grading System. And this system is a 2-tiered grading system. And to get into the high-grade category, need either a mitotic index of 5 per 2 square millimeters or more, or a Ki-67 proliferate index of 5 or more, and or tumor necrosis. And it's important in the pathology report to mention the mitosis and the Ki-67 as continuous variable, because the prognosis worsens as the proliferative activity of a tumor increases. When you look at the data for this international medullary thyroid carcinoma grading system, it's very clear that in every survival endpoint, whether it's overall, disease-specific, local, regional, or distant metastasis-free survival, it's really separating the patients very well. Just to give you numbers here, the 10-year disease-specific survival, if you have a low grade, is 97%, and it drops to 53% with high grade. The 10-year distant metastasis-free survival for low grade is 84%, and it drops to 31% for high grade. And the prognostic significance of this consensus grading system was maintained for each participating site in regard to overall disease-specific and distant metastasis-free survival. Only for local regional free survival, we were not able to reach significance for the Italian cohort. But perhaps the most important slide for this medullary thyroid carcinoma is here. This is the multivariate analysis, and you can see that this grading system is independent from very important other prognostic parameters, including stage, tumor size, postoperative CA and calcitonin, external margin status, age, extrathyroid extension, and vascular invasion. Now, this system was validated by an Italian group in an independent cohort of 111 cases. It predicted survival in disease-free survival in the entire cohort, including in sporadic medullary carcinoma. I don't know why they could not reach they could not predict survival, overall survival in the cohort, but they predicted disease-specific survival. And a study from Brigham and Women's showed that this tumor is reproducible among academic pathologists. Just to bring this to life, so to speak, this is a 66-year-old male with no distant met at presentation. This is clear medullary carcinoma. You can see the calcitonin stain on the right, the necrosis, again here with no nuclear pleomorphism, and the patient unfortunately died of disease 2 years and 3 months after thyroidectomy. So what are the remaining issues for this grading? We still do not know the real relation between mutation and grade in sporadic tumor. One paper showed no correlation between grade and sporadic mutation, but it was a small cohort done by Dr. Violetta from Brigham. Another study from Paris showed the independent value of red vis-a-vis grade. We still don't know, the jury is out, but now we are doing a big genotyping study on this large cohort, and soon we will have the results. So what's the purpose of all this hard work is we hope that because patients with high-grade medullary carcinoma have a worse outcome, they may benefit from early lateral neck dissection, close follow-up, low threshold for cross-sectional imaging, and careful workup for distant metastasis. Also, this can be used as data point for clinical trial because one will assume that high-grade patient may benefit more from adjuvant therapy. So basically, I would like to close this talk by showing you that we are really going toward a new nomenclature in tumor that better reflects behavior. That was done a few years ago with the staging system that went from anatomic staging to anatomy and prognostic staging. And you can see here that for histopathologic entity, we should base the definition on prognostic irrelevant histologic feature rather than clinically irrelevant histopathology, because we look, as Dr. Reuter, the Vice Chairman at Memorial said, because at the end, we pathologists are simply clinicians with a microscope. And here I would like finish with this statement from Julian Huxley, who was a well-known British biologist who said in 1958 in a lecture at the Sloan-Kettering Institute, just a few hundred meters from my office, that cancer malignancy must be defined according to what the tumor cells do, not what they look like, otherwise the term ceases to have biologic meaning. And if we had done this with the follicular event, we would have spared a lot of patient unnecessary treatment and side effects. So this is the end of the talk. Thank you.